In the high-stakes realm of trauma care, rapid and precise decision-making can mean the difference between life and death. Central to this approach is the fundamental principle encapsulated by the ABCs: airway, breathing, and circulation. However, the essence of trauma care extends beyond this initial triad, requiring clinicians to adapt and innovate in response to the dynamic nature of each situation. Navigating the ABCs: 1. Airway. Ensuring a clear and patent airway is paramount in trauma care, as compromised airway management can quickly lead to hypoxia and respiratory failure. Swift assessment and intervention, including airway positioning, adjuncts such as oropharyngeal and nasopharyngeal airways, and advanced techniques like endotracheal intubation are essential to maintain adequate oxygenation. 2. Breathing. Effective breathing relies on intact respiratory mechanics and adequate gas exchange. Clinicians must assess for signs of respiratory distress, such as tachypnea, dyspnea, or paradoxical chest movement, and intervene promptly to address underlying issues, such as tension pneumothorax, hemothorax, or flail chest. Techniques such as needle decompression, chest tube insertion, and positive pressure ventilation may be necessary to optimize breathing. 3. Circulation. Adequate circulation is vital to deliver oxygen and nutrients to vital organs and tissues. Hemorrhage control takes precedence in trauma scenarios, with immediate measures such as direct pressure, tourniquet application, and hemostatic agents employed to staunch bleeding. Intravenous access and fluid resuscitation strategies guided by hemodynamic monitoring and clinical response aim to restore and maintain perfusion. While the ABCs provide a foundational framework for trauma care, effective management extends beyond these initial priorities. The primary and secondary surveys, imaging modalities, and multidisciplinary collaboration play important roles in comprehensive trauma assessment and treatment. Fluid resuscitation is a necessary intervention that can significantly impact patient outcomes. However, the timing and approach to fluid administration must be carefully considered to optimize results and minimize complications. Delayed fluid therapy. Studies have revealed a counterintuitive finding. Delaying fluid resuscitation in trauma patients can actually improve mortality outcomes. Aggressive fluid therapy in the early stages of trauma can dislodge soft clots and lead to dilutional coagulopathy, exacerbating hemorrhage and increasing mortality. Therefore, the priority is to stabilize the patient and proceed with prompt surgical intervention before initiating fluid resuscitation. Premature fluid therapy. In certain scenarios, such as crush injuries, fluid therapy should be initiated even before the primary issue is resolved. This preemptive approach aims to prevent the release of toxins such as myoglobin, which can induce acute renal failure via myoglobinuria. By expediting urine output, this strategy helps protect vital organs like the heart and kidneys. Fluid overload risks. While fluid resuscitation is essential, overgenerous administration during abdominal or visceral surgical procedures can lead to postoperative complications. These may include shortness of breath, tachycardia, and the presence of bilateral rails on physical examination, indicating fluid overload. In such cases, diuretic therapy may be necessary to address the fluid overload state and restore balance. As far as trauma care is concerned, a thorough understanding of compartment syndrome is needed, as it represents a potentially life-threatening complication that requires prompt recognition and intervention. Aggressive fluid resuscitation, while necessary in trauma care, can inadvertently lead to a rise in intra-abdominal pressure, resulting in abdominal compartment syndrome. This condition occurs when increased pressure within the abdominal cavity impairs blood flow to vital organs, leading to organ dysfunction. Immediate decompression of the abdomen through surgical intervention is necessary to restore organ perfusion and prevent further complications. Elevated intra-abdominal pressure can also predispose patients to wound dehiscence, a condition characterized by the surgical incision reopening, typically around a week after the procedure. Wound dehiscence poses significant risks, including an increased mortality rate, particularly if evisceration occurs, where abdominal contents protrude through the wound. Compartment syndrome, whether abdominal or in other anatomical regions, requires vigilant monitoring and timely intervention to mitigate risks and optimize patient outcomes. By recognizing the signs and symptoms of compartment syndrome early and implementing appropriate management strategies, healthcare providers can effectively address this dangerous complication in trauma care settings. In trauma care, the primary survey is the initial assessment conducted to rapidly identify and address life-threatening conditions. It follows a systematic approach, often abbreviated as ABCDF, with each step prioritizing critical interventions. Danger. The primary survey begins with identifying and mitigating immediate dangers to both the patient and the medical team. This may involve removing the patient from hazardous environments or ensuring scene safety to prevent further injury. Response. Assessment of the patient's level of consciousness is crucial in determining neurological status and guiding subsequent interventions. Providers evaluate the patient's responsiveness to stimuli, such as verbal commands or painful stimuli, to gauge their neurological function. Circulation. Evaluation of circulation is paramount in identifying and managing shock or hemorrhage, which are common life-threatening conditions in trauma. Providers assess vital signs, peripheral perfusion, and signs of active bleeding to initiate appropriate interventions promptly. Airway. Ensuring a patent and secure airway is vital for adequate oxygenation and ventilation. Providers assess for airway patency, addressing any obstructions or compromised breathing, and intervene promptly to establish and maintain a clear airway. The primary survey follows a structured approach to quickly identify and address immediate threats to life, allowing for timely interventions and optimization of patient outcomes in trauma care settings. Following the primary survey, the secondary survey provides a more detailed evaluation of the patient's condition, focusing on identifying additional injuries and assessing for potential complications. This comprehensive assessment helps ensure that all injuries are identified and addressed, minimizing the risk of misdiagnoses and improving patient outcomes. Obtain a detailed history. Providers obtain a thorough history of the patient's condition, including any relevant medical background, the mechanism of injury, and the circumstances surrounding the trauma. This information helps guide further assessment and treatment decisions. Measure vital signs. Vital signs, including blood pressure, heart rate, respiratory rate, and oxygen saturation, are measured to identify any abnormalities that may indicate underlying injuries or physiological disturbances. Monitoring vital signs allows providers to track the patient's condition and response to treatment. Conduct a comprehensive physical examination. A systematic physical examination is performed, focusing on evaluating all body systems for signs of injury or dysfunction. Providers assess for any missed injuries or potential complications that may have been overlooked during the primary survey. Special attention is paid to areas of pain, tenderness, swelling, or deformity. The secondary survey plays a crucial role in the comprehensive assessment of trauma patients, helping to identify all injuries and ensure that appropriate treatment is initiated promptly. By conducting a thorough evaluation, providers can address both immediate and potential long-term consequences of trauma, improving patient outcomes, and reducing morbidity and mortality. Ensuring adequate airway management is paramount in trauma care, as compromised airways can rapidly escalate into life-threatening situations. Recognizing signs of airway compromise and promptly addressing them is crucial for patient safety and outcomes. Verbal communication, effective verbal communication from the patient, such as coherent speech and responsiveness to questions, generally indicates a patent or open airway. Patients who can communicate effectively are likely maintaining adequate airflow. Airway. Compromise. Several conditions can compromise the airway and require immediate intervention. These include cervical spine injuries, foreign body aspiration, emphysema of the neck, such as in cases of pneumothorax or subcutaneous emphysema, or expanding neck hematomas. Emergency personnel must be vigilant in identifying and managing these situations promptly. Partial airway obstruction. A partial airway obstruction may manifest as high-pitched breath sounds or stridor, indicating a constricted or partially obstructed airway. Recognizing these signs allows for early intervention to prevent further compromise and ensure adequate oxygenation. Complete airway obstruction. In cases of complete airway obstruction, patients may exhibit no audible signs of distress due to the absence of air movement. However, the lack of respiratory sounds requires immediate recognition and intervention to clear the obstruction and restore airflow. Effective airway management hinges on the ability to recognize signs of compromise and intervene promptly to maintain adequate oxygenation and ventilation. Healthcare providers must remain vigilant and prepared to address airway issues swiftly to optimize patient outcomes in trauma scenarios. Assessing breathing is a critical component of trauma care, as adequate oxygenation is necessary for maintaining vital organ function and preventing hypoxic injury. Knowing how to interpret oxygen saturation levels and recognize signs of hypoxia is a requirement for timely intervention and patient stabilization. Pulse oximetry. Pulse oximetry is a valuable tool for assessing breathing and oxygenation. It measures the oxygen saturation, SpO2, of arterial blood hemoglobin, providing real-time feedback on the patient's oxygen levels. Hypoxia. A patient is considered hypoxic when their oxygen saturation falls to 94% or less. Hypoxia is a clinical emergency that requires immediate intervention to restore adequate oxygenation and prevent further deterioration. Cyanosis. Cyanosis, characterized by a bluish discoloration of the skin and mucous membranes, is a visible sign of severe hypoxia. It typically occurs when a patient's oxygen saturation is less than 90% and may be accompanied by other clinical signs of respiratory distress. Continuous monitoring of oxygen saturation, coupled with prompt assessment and intervention, is a necessary part of optimizing patient outcomes and preventing hypoxic complications. In trauma care, maintaining adequate circulation is critical for preserving vital organ perfusion and preventing systemic shock. Understanding the causes and consequences of disordered circulation is essential for effective intervention and patient stabilization. Hypovolemic and hemorrhagic shock. Compromised circulation often occurs in hypovolemic and/or hemorrhagic shock, where the body loses significant blood volume. Hemorrhage can originate from various sources within the body, including the thorax, peritoneum, or retroperitoneal space. Rapid identification and control of the source of hemorrhage are critical for preventing further blood loss and stabilizing the patient's condition. Brain hemorrhage misconceptions. Contrary to popular belief, brain hemorrhage is not a primary cause of massive blood loss or hypotension in trauma situations. The brain does not contain enough blood volume to significantly impact the overall circulation. While brain hemorrhage is a serious condition requiring urgent intervention, it typically does not lead to systemic shock solely due to blood loss from the brain. Prioritizing interventions. In trauma scenarios, clinicians must prioritize interventions that address the underlying cause of disordered circulation. This includes controlling hemorrhage through direct pressure, tourniquets or surgical intervention, as well as restoring fluid balance through appropriate fluid resuscitation strategies. Early recognition and management of disordered circulation are crucial for optimizing patient outcomes and preventing complications associated with systemic shock. Crush injuries pose unique challenges in trauma care, often leading to significant tissue damage and potential complications such as compartment syndrome and acute renal failure. Effective management of crush injuries requires prompt and aggressive fluid resuscitation strategies to mitigate the risk of further complications. Early initiation of fluid resuscitation. Emergency personnel must initiate aggressive fluid resuscitation for patients with crush injuries as soon as possible, even before the crush situation is fully remedied. The goal is to prevent the release of toxins, such as myoglobin, from damaged muscle tissue, which can lead to acute renal failure via myoglobinuria. Protecting the heart and kidneys. Aggressive fluid therapy aims to protect both the heart and kidneys from the deleterious effects of crush injury-induced complications. Leaked intracellular potassium from damaged muscle tissue can lead to dysrhythmias, while myoglobinuria can cause renal tubular casts, contributing to acute renal failure. By expediting urine output, fluid resuscitation helps flush out toxins and mitigate the risk of renal complications. Adjunctive therapies. In addition to aggressive fluid resuscitation, adjunctive therapies such as sodium bicarbonate or mannitol may be used to further expedite urine output and prevent the development of acute renal failure. These adjunctive treatments can help optimize renal function and minimize the long-term impact of crush injuries on kidney health. Conclusion: aggressive fluid therapy is a cornerstone of management for crush injuries, aiming to protect vital organs and prevent further complications. Early initiation of fluid resuscitation, along with adjunctive therapies, plays a crucial role in optimizing patient outcomes and minimizing the long-term effect of crush injuries. Trauma care demands a systematic and thorough approach to effectively manage potentially life-threatening injuries. A comprehensive approach involves integrating key principles and protocols to optimize patient outcomes. Primary survey. The primary survey is the initial assessment aimed at rapidly identifying and addressing life-threatening conditions. Following the DRCAB sequence, danger, response, circulation, airway, breathing, healthcare providers prioritize interventions to ensure the patient's immediate safety and stabilization. Secondary survey. Once life-threatening conditions are addressed, the secondary survey begins. This phase involves obtaining a detailed patient history, measuring vital signs, and conducting a comprehensive physical examination to identify any additional injuries or complications that may require further evaluation or treatment. Fluid resuscitation strategies. Fluid resuscitation plays a critical role in trauma care, but its timing and approach are crucial. While aggressive fluid therapy may be necessary in certain scenarios, such as crush injuries, it should be delayed in favor of prompt surgical intervention in others. Understanding the unique needs of each patient and tailoring fluid resuscitation strategies accordingly can help optimize outcomes and minimize complications. Conclusion: trauma care requires a multifaceted approach that encompasses both rapid assessment and thorough evaluation. By following established protocols and adapting interventions based on individual patient needs, healthcare providers can deliver effective and timely care to trauma patients, ultimately improving their chances of survival and recovery.